Hi everyone, my name is Michael, and together with my team, this is my project on the comparison of demographics and outcomes of Nstemi Ua in the pre and peri-COVID-19 pandemic. So let's just set a few things straight. When I say Nstemi, I'm referring to non-ST elevation myocardial infarction. When I say UA, I mean unstable angina. And both of these are forms of acute coronary syndrome or heart attacks. Now, the background for this project comes from research throughout the pandemic. At the beginning of the pandemic, it was noted that the number of people going to the hospital with heart attacks had declined. But as the pandemic went on, patients presenting with a certain kind of heart attack, ST elevation myocardial infarction or STEMI, those patients suddenly had an increased number of people coming in and they were presenting in a worse clinical picture. So while that was shown for STEMIs, that relationship has yet to be shown for patients coming in with Nstemi and UA. So that's where this project comes into play. We wanted to compare the pre-COVID period patients with Nstemi UA to those during the pandemic or peri-COVID to look at what were their risk factors like, how were they managed, and what their health outcomes were like. So these are the key findings then summarized. And so I've got here the pre-COVID and the peri-COVID demographics. What we noticed when looking at the risk factors of these patients, the peri-COVID pandemic patients were notable in that fewer of them had a past history of heart attack. What was also notable is that these patients did not differ in terms of their traditional heart risk factors. So there was no difference in terms of like the number of patients that were previous smokers or had high blood pressure. When you look at the severity of their presentation, similarly, the patients presenting during the pandemic had increased severity as noted by increased left ventricle and diastolic pressure. If you look at the health outcomes of these patients, again, the patients during the pandemic had worse outcomes. They had an increased need for mechanical support, increased need for respiratory support, increased incidence of cardiac arrest. What's notable though is that these patients didn't differ in terms of their mortality. Now, what we think might be what we might attribute these differences to rather is the time from symptom onset to medical contact. And what you'll notice is that in the pre-COVID period, these patients presented sooner to medical contact from symptom onset. Now, there could be lots of reasons why they delayed seeking medical care. Maybe they were trying to avoid catching COVID in hospital, or maybe there were long wait times. But this seems to be one of the reasons that might explain why there was worse outcomes. So, to summarize, in the pandemic or during the pandemic, patients presenting with Nstemi and UA didn't differ in terms of having a rebound number effect, but they did differ in that they presented in a more severe picture and have worse health outcomes. To target this then, we would focus on patient education and rural resource allocation to improve that symptom onset to medical contact time, as well as better risk stratifying patients that are coming in with Nstemi and UA to avoid some of those adverse health events. The future directions of this project is going to look at the angiographic and coronary severity of disease for these patients. And just to conclude, I'd like to thank the Royal University Hospital Foundation and the College of Medicine at the University of Saskatchewan for their funding. Thanks.